Hi, welcome back. And today we have another melanoma specialist, and this is Dr. Deborah Sarnoff, who is a dermatologist and Mohs surgeon. And he is actually she is actually one of the premier specialists in cosmetic dermatology, laser surgery, and Mohs surgery for treating patients with skin cancer. She is a clinical professor of dermatology at New York University Medical Center. And in addition, Dr. Sarnoff served on the board as well as the president of the Skin Cancer Foundation in New York. And one of the things I was really delighted to have a chance to interview Dr. Sarnoff is you've been practicing with your husband, who is a board certified plastic surgeon together. So you have lots of wisdoms about reconstructions, about correcting scars. And Dr. Sarnoff have been interviewed widely by, Today shows, the 2020 Good Morning America, and Dr. Oz, because of all those publications and lectureship and that you've done over the years. So again, welcome. Thank you so much for taking the time to join us on the Beating Melanoma project.
Thank you for having me, Dr. Wang. And I think it's a wonderful thing that you're doing a book like this. I think Beating Melanoma is going to be a wonderful resource to all that see it and read it. So thank you for doing that.
No, thank you. We got a lot to cover. And one of the first thing I want to know is you are a surgeon, right? And most patients who come to see you for skin cancer, for melanoma, they're just sort of terrified. How do you alleviate their stress and concern and fears?
It can be a devastating diagnosis, but the first thing I always do is I sit down with a patient and I try to go over the biopsy report, and I try to explain to them that not all melanomas are the same. And it can be a scary term, but there are many melanomas when they're found early and they're superficial in the skin. We have ways of dealing with them that are simply to excise and reconstruct, and they really don't need any adjunct therapy. So I want to put it in perspective, first of all, what they're really dealing with. And I want to educate them about where it's coming from the melanocyte, which is, we know, a cell in the skin. Something's gone awry. There's been a mutation. These cells are overpopulating. And the name of the game surgically is we not only need to get the melanoma out, but we want a safety border or a margin so that we can kind of assure the patient that we've taken it all out surgically. And it can be devastating because very often, as you know, it can be on the face. It can be in an area that is going to be seen by other people. And so now you have a twofold problem. Patients worried that they might die of their disease, and patients worried about cosmetically, will they be deformed and how are they going to look afterwards? So we have to kind of separate out the issues and deal with them one by one.
No, that's a really great answer. So, you obviously perform most of those surgeries in the clinical setting, right? In the office, etc.
Right.
Can you just walk us through, let's say, a patient that's coming to your office, what does that day look like? And what do you tell them about post-op care? And, should they, well, even pre-op, should they take their medication? And just walk us through so someone who may not have access to you so they can understand what that process is like.
Sure. So if we're talking about an early enough melanoma where we don't need to investigate lymph nodes and we don't have to send them on to maybe a tertiary care center or the hospital, or maybe something where they're going to have their lymph nodes removed, and it's simply going to be an excision, then we usually meet them first in consultation. And we want to tell them that on the day of surgery, they can eat a good breakfast. They're not going to be knocked out typically with general anesthesia or even IV sedation, but it's going to be done under local. And most people can relate to that for having been to the dentist.
Sure.
In our practice, I'm very fortunate to work with my husband. So we want to tell them that actually it's a one-stop shop. And when they have their melanoma excised, they're going to be whole again because they will be repaired or reconstructed on the same day. Some of the melanomas, I, as a dermatologist and a dermatologic surgeon, as you well know, we're able to handle those. And others that might require a little more finesse, or maybe the melanoma is in a more critical area, very close to the eyelid or the nose, might be beneficial to have working with a plastic surgeon. so that they can have reconstruction by someone who has that fine-tuned skill set that they might require. But we tell them to eat normal breakfast, and perhaps if they're on blood thinners, we check in with them beforehand and see if we might be able to stop them. They have to consult their doctor who prescribes the blood thinners, because sometimes they really cannot be stopped and sometimes they can. And there are circumstances where if they cannot be stopped, we work around it. We still will excise the melanoma because that's important to remove the bad cells with a nice safety margin. And we reassure them we are able to stop the bleeding in the clinic. And when they go home, they might have more bruising, but to stay in touch with us, because sometimes there's a risk-benefit ratio, and there are people that have had strokes or
Sure.
have problems where they really can't stop the blood thinner. But as we know, melanoma must be treated. We tell them that it's going to be about a 1-hour procedure, maybe 1.5 hours total. And if they feel like they need a little tranquilizer or something, we do have a little Valium for them, but it's really nothing that they have to fear. They're going to be okay. That's basically what we tell them.
Yeah, a couple other things I just like to add. So I usually tell my patient, if they can avoid fish oils, right, and as well as, let's say, ibuprofen for pain at least 7 days before, because those are not critical, but they can cause increasing bleeding. And
Question about that. And nowadays there's just so many medicines that people are on, that we ask them for just a list of the medicine, and we do ask them supplements beforehand. And that's a very good point, because it's important, I think, for people to tell the physician everything that they're taking, because they may think it doesn't relate, and it might. And it's always going to be easier. And we're talking now about the cosmetic result. What we don't want, if we can prevent it, we don't want what's called a hematoma, and to have blood underneath the wound that's going to swell everything up, might even open up the suture line. We want to stack the odds that it's going to be a really nice healing and the best scar that we're able to give somebody, and the best cosmetic results. So that would be an important thing to go over, all the medication.
yeah, so always we talked about the risk of pain, infection, bleeding, and scar. Hematoma is obviously one of them. And do patients come back and 7 to 14 days later for suture removal at your office, depending on the location, I assume, right? Basically.
Let me just stop this, sorry. Patients do come back. Sorry, patients do come back.
Let me ask you the question again so we can
Fine.
sort that out. So,
wait 1 second. Let me shut this off. So sorry. Let me just shut this off. Hang on. Okay, go ahead. Yes, go ahead.
I'm going to ask you again. So,
Okay.
When do you bring the patient back for suture removal?
So suture removal depends on where the melanoma excision has been performed. Quite typically, if it's on the face, we might bring the patient back for between 1 and 2 weeks, depending. If it's on the trunk, it might be more like 2 to 3 weeks, depending. And if it's on the lower extremities, it might even be 3 to 4 weeks, depending. And those things have to do with how we've sutured, maybe what the size of the suture line is, or if a graft was needed. But in general, we know that the circulation is better on the upper part of the body. And so sutures are going to come out sooner on the face, a little bit later on the trunk, and perhaps even later on the lower extremities.
Yeah, and the one other thing I always tell patients is when they take out the sutures, let's say 10 days or so, the wound is only about 10% of its initial strength. And then also tell patient there's another layer of sutures underneath, and they call it subcutaneous absorbable suture that still holding the tissue together, so they have to take it easy a little bit.
Right. We know that those, as you know, usually dissolve between 90 and 120 days, but we also want to stress to the patients that there are phases of wound healing.
Sure.
And beginning, we call it the inflammatory phase, and our blood cells are coming to the area, and it could be a bit inflamed, and it's a fresh new wound. And most people will listen to us and take it easy when the sutures are still. You're quite right. Once we remove the sutures, what may happen maybe at around a month and a half's time, Sometimes it can look lumpier or more inflamed, and patients will be a little concerned, is something going wrong? And I try to explain that that's usually what we call the proliferative phase of healing, and that maybe more blood is summoned to the area, and it might look like something's going wrong, but honestly, the underneath sutures are still there. They're going to eventually dissolve, and your body is trying to make collagen, which is, the strong protein in our skin that's going to actually give the scar its strength to be a good scar. And that's a normal part of healing. And then eventually, maybe after 2-3 months, the proliferative phase is over, but you still have a remodeling phase that could go on for a year or even longer, where everything's going to be okay. Things are going to settle down. No one really has a red, angry scar forever. Things usually, most people understand that the scar eventually becomes flatter and usually either lighter or darker than your surrounding skin, usually lighter, but it's going to be okay. It's just at the beginning, people can worry because the scar does go through phases of maturation.
So along the same line, this is a really wonderful summary. I didn't expect you're going to go into the 3 phases of wound healing, but this is great. Let's just say the scar does not turn out to be ideal, right? And what can you do to correct it? I mean, first of all, there's different types. There's a hypertrophic scar, there's keloid, there's pigmentation. Maybe we can walk through the different scenarios and can walk us and talk about what treatment options that you have.
Well, there's always hope. And I like to quote my mentor, who's still alive, 92 years old, Dr. Perry Robbins, very wise man. One of the pearls I picked up from him when I was a fellow, things, first of all, do have a way of resolving themselves. But his famous line was, sometimes you have to do the least in the most amount of time, because I think that tincture of time is a really important thing. With that said, people have to live their lives, and people are worried, and they don't really want to hear that it's going to be okay in a year. They want to know, what can they do now, or how can we kind of make things better? So I do think you have to separate out, there's a subgroup of population, and we know that maybe it's a little bit more in people of color, certain ethnic groups that are prone to keloids. Sure. And usually you're a keloid former. You usually know that by a certain age. Maybe you've had your ears pierced and you've gotten lumps from that. Maybe you've had your appendix out, or you've had some kind of elective surgery or a trauma, and you've developed a scar that's kind of out of control, growing way more than a normal scar. And a good surgeon is going to ask you, usually before you have your melanoma removed, do you have a tendency to keloids? Do you have a problem with scarring? And if you do, you need to speak up, because if we anticipate that, we still have to take the melanoma out, but we'll be that much ahead of what we can plan for and what we can do. And if you do have that problem with keloids, there is help even for that, because sometimes, as you know, we can inject a cortisone, a steroid, into the actual keloid. Sometimes we can use liquid nitrogen, very, very cold, applied to the scar. There are methods. Sometimes, I mean, in a person, if it's a devastating keloid, we might even use a little low-dose radiation. But there are ways to get keloids to calm down and not be inflamed and itchy or painful. And it would not be a reason not to take a melanoma out surgically because you had the keloid tendency. We just have to know about it. There are other instances where you don't have a keloid tendency, but maybe you develop a raised scar, and maybe the raised scar really is bothering you cosmetically, particularly if it's on your face, or maybe in the case of some women on the chest, on this area, the décolletage. So we do have methods. Early on, we often recommend that patients, first of all, use sunscreen over their scar, because that's going to be very helpful. Number 2, we might have them topically apply something with silicone. It can either be a gel, or it can be a kind of a patch, an occlusive patch. And we know that by keeping that patch on or applying the gel, There's something about the moisture in that patch against the skin that can help make the scar less red and less raised and calm it down. So we often do that. Sometimes we will inject the steroid into the scar in the office, and that is helpful too at calming things down. So we definitely have ways to modulate the scar. We sometimes use lasers on scars if the scar is too red because there's too much blood in the area and it's very inflamed. There's a group of lasers that only see red, such as the pulse dye laser, which can be employed to help the scar. If the scar is too dark and it's really looking very brown compared to the surrounding skin, we might use a different group of lasers, like the Q-switched pigment specific lasers. So we do have a lot of things in the toolbox. You know, even lately, there have been articles on actually botulinum toxin, which most people have heard of, like Botox or something like that, being injected into scars that can help flatten down the scars and make them less inflamed. So we have a lot of tools in the toolbox as dermatologists to help deal with scars. And in the planning, you know, that's very important too. My husband and I, as we work together as a team, you know, you might want to, if the melanoma is right on the nose, we might want to look, how does the light hit the nose? And before we go taking a skin graft and just making it a circle on someone's nose, maybe you have to change the shape a little bit into a parallelogram or a rectangle of sorts because it's going to look better. Or maybe the melanoma is on the side of the face, and rather than just stitch it in the middle, if it's an older person, maybe a little bit of a facelift, a little bit of a nip tuck, and trying to put the suture line where the ear meets the face is going to not only take out the mandatory margin of normal skin around the melanoma, but aesthetically and cosmetically, it'll make the patient happier because they're going to look better. So there's a lot of finesse that goes into which way we should orient the scar, what we should do in terms of suturing. We don't want to put those old-fashioned sutures over the skin. If we can help it, we'll bury everything and do what we call a little running subcuticular. We take cosmetic into concern, even with cancer, because it's important.
Yeah, it's very important. I mean, I think the most melanoma survivors sort of see this, right, and have this kind of emotional stress associated with seeing this. So I want to ask you, what does your patient do? Now you got one side of the face that looks 10 years younger. Now they have to wait to grow another skin cancer on the other side. Well, I want to ask you that. But so we touched a lot already, right? But let me ask you this question. That is, now imagine yourself, let's say you are someone who is a melanoma just diagnosed, and you want to find the best dermatologic surgeon or just general surgeon, plastic surgeon, anyone that will remove this. How do you do the research? How do you sort of qualify someone? How do you, when you go in, what aspect, characteristic of that surgeon you should be looking for?
Well, I do think the first thing is truth in advertising, and we want a board certified physician, and we want a board certified physician in what are the legitimate boards. And so in answer to your question, first of all, you can find out who's passed their boards in dermatology. And I think dermatologists, we are experts in the skin, hair, and nails. And if it's a relatively early melanoma that does not require lymph node removal, that would be a terrific choice. There's board certification. You don't want to just see the words board certified because you don't know in what. So you want specifically either that, perhaps in plastic surgery, but even there, I think you want somebody that has a track record in dealing with melanoma and reconstruction. You don't necessarily want the person that does, breast implants all day long.
Yeah.
Be the right choice.
Yeah.
If you do need the lymph nodes out, then we're looking more maybe at what we call head and neck or general surgeon. But I think that you could start with your primary care doctor and get some names. You could start with, an internet search. And one thing that I think is also very good is the Skin Cancer Foundation, which I happen to be president of. We have a website, skincancer.org. And on that site, you will find out a host of information about melanoma and about cutting edge treatments of melanoma. But there's also a guide there to find a doctor. And these are people that are already vetted, that have passed their boards, they're dermatologists, and they have an interest in treating skin cancer. Also, the American Academy of Dermatology and the ASDS, which stands for the American Society of Dermatologic Surgery, they have websites that would have doctors that you can't be in these societies unless you are vetted. And once again, this is your area of expertise. So I think that there are ways. I would not necessarily trust some of the online reviews because I don't think that some of them are paid for, and some of them may just be people that have an axe to grind that maybe had a long wait in the waiting room or something that wouldn't be relevant to the expertise and the abilities of the doctor. And you might ask around also for if you have family or friends that have had melanoma with a positive experience from the whole thing, that would be another way to go as well, to find, I think, a doctor that is well suited to take care of you. And you can interview more than one, because as much as we want to excise clear margins around a melanoma, when you find out you have a melanoma, I don't think it has to be done the next day. I think if you want to do your due diligence and take a couple weeks to go and find the person you feel the most comfortable with, that's okay too.
Yeah, it makes a huge difference. And not only the physician, but the staff and the whole office, everything makes a huge difference. I think we're going to segue to something you mentioned it, because not only you take care of patient, your lectures and you write papers, but you have another very, very important job. And you're the president of the Skin Cancer Foundation. And I've already interviewed Dan, the executive director, but tell us a little bit about, one thing, maybe one reason why patients with melanoma should go see the Skin Cancer Foundation. What is this organization? And
I think when you get that diagnosis, it can be the most frightening thing you've ever heard. And I think that family and loved ones and friends are going to be asking you a million questions, and they all think that they want to help. And I think one thing you can do is you can refer them to that site. It's a wonderful source of education to tell a newbie who just got a melanoma what it's all about. And with the social media component, it can hook you up to Facebook for melanoma patients to speak with one another. It's all anonymous. It could be, online. But sometimes I think there's a great deal of comfort in knowing you're not alone, and other people have walked that road, and they can inspire you and encourage you. And I think that's great. I know you said one thing, but I just want to also say
keep going.
In general, the website skincancer.org is just fantastic because it has cutting edge treatments. And if the melanoma ever did come back, recur, or you were in a position where the melanoma was deeper than what could just be done with surgery alone, and you needed some additional immunotherapy or targeted therapy, as we call some of the therapies, it's overwhelming as a lay person to first hear all these terms. And I think that the Skin Cancer Foundation is a one-stop shop to go online and educate yourself. And it's a great place to send people who love you, so that you don't have to keep explaining, because it talks about cutting edge therapy. And also there's quite a bit of research being done now. And for anyone that wants to get involved, I think that the clinical trials and the things that are going on now, if you qualified or wanted to know more, that would be a great source of information. So I just think it's a wonderful resource, and it's dedicated solely to skin cancer. So unlike some of the other sites which talk about different cancers, this is devoted to skin. And I think it's very helpful and comforting to patients.
Yeah, and I'd just like to add, this is not only for melanoma, basal cell, squamous cell, but there's also other aspect like I'm involved with the photobiology committee that we review all the sunscreen, make sure that product is safe, effective, and
you sure are involved. You're our chairperson. We couldn't do it without you. And I think that's important for lay people to understand that when you are reading a label on a sunscreen, what is that all about? And our photobiology committee reviews all of these applications for the sunscreens that do have the seal of recommendation awarded to them from the Skin Cancer Foundation. And they can't get that seal by just paying. They have to earn that seal by their products really meeting certain benchmarks and criteria, which the photobiology committee analyzes all of that data. So that's a very important thing.
Well, Dr. Sarnoff, I just want to thank you again for your time and your insight about, what is it like to do the surgery for the melanoma patient. And specifically, I was really curious to hear about, the cosmetic scars, how do you improve it? And you touched upon a lot about how do you design it and what devices do you have, what treatment you have. And again, thank you so much for your time.
My pleasure. And just for everybody out there listening, there's always hope. And even though there's going to be a scar, we can make the nicest, prettiest, almost imperceptible scar there is. So encouragement for everybody. And thank you so much, Dr. Wang, for sharing your insight and for publishing this book.
Take care.